Hey everybody, welcome to BrucknerOncology.com. Bruckner Oncology. I'm here with Dr. Howard Bruckner from the Bronx. He just wrapped up a busy day at the clinic. They're doing a lot of studies, they're doing a lot of treatment with patients. It's a clinic, it's an infusion center, and they do research studies. So Dr. Bruckner runs it all. How's the study going? It's been a while since we last spoke.
Some days it runs me. They're going well.
Okay.
Well, volume uh, is beginning to pick up. We have a number of candidates in different disease categories, and there, there's some insights. It turns out to really be important to be able to do good supportive care and comprehensive management, uh, getting people started, opportune moment, and have them in condition where they can take advantage of treatment.
Oh,
What we're
okay.
learning, what we're learning is the earlier the better. Uh, just saw this article in the Times, uh, Science Times this week. They were asking when should you do immunotherapy, when is it too late? And, what we're seeing over and over is the mistake is to get to that question. Uh, the time for the immunotherapy is a little earlier in the game than you might think. And it's important for people to do their homework and have their options in place before things fall apart. And that seems so obvious. And as someone who takes care of a lot of patients and tends to get problem patients forever, uh, it's just the most obvious thing that people have opportunities that just go by because they're not doing their homework in time, and they don't know that it takes time to, to change treatments and make things happen. And people should have all their options in place and really be hard-nosed about whether or not their treatment is working. Not there's so many good things now to be casual about whether or not the first treatment is working just isn't acceptable anymore. And it surprises me over and over that people come in, intelligent people, people with family resources, professionals in the family, and they're, I'm not sure what the right word is. They're not acting in timely fashion. They, they sort of know there are other things out there, but they don't do their homework so that they can find them at the ideal moment. Now, I'm, if I say so myself, pretty good at pulling the pieces together so that the patient gets back into shape and we can do things. But just because I can do it doesn't mean that that's the ideal. Much better not to have to pull the patient back from the brink. And yeah, we're, we're trying to get that message to our referring doctors. But there must be a lot of psychological barriers. I was just really upset. There was an article, as I said, this week in the Times, and there was another article just last week, Sunday, in the Times. A professor in San Francisco, a non-oncologist, was saying, gee whiz, all this new oncology, immunotherapy, it's miraculous. And then she says, uh, miracles are problems because we used to know that we could give up. Now we
Yeah.
don't know when to give up. And to me, that's just not the right thinking. It doesn't give you the right integration of opportunities. It's not waiting and deciding when someone's deep in trouble. Although, yes, these days you, like we just have two people now going into study, and a lot of people would have said no, don't do it. But
Why would
we've
they have said
managed.
no?
Patient was sick, had a lot of fluid, wasn't eating that well, uh, and some people would have said, uh, the time has passed. But we know that was never true. Uh, the patient was, these people are very intact. They're totally with it. They're up. They're able to travel. They're moving around, and people are not. They're not taking advantage of time that patients have. And you know, obviously, I have a bit of a prejudice because this is the area that I chose to work in. People with problems. Uh, One of my friends, doctor, says you're the equivalent of the high risk OBGYN doctor. You're taking the difficult ones. Uh, but the point is, it's a whole specialty because if you know what you're doing and you have experience, you end up with good babies and well mothers, and cancer patients can end up with good quality time often. So, well, uh, you just see it every day, and uh, with this business in the Times, it bothers me because that's not the question. The question is make the decision before there's a crisis. That's the ideal. And I had two people in the office today who got immunotherapy for crises 2 and 3 years ago when immunotherapy was really a new thing. And they got into such good shape that they've run on chemo that they weren't able to get before they responded to the immunotherapy. So the whole algorithm of when, what, and it's not this talk about last resort, should you try one more time, bugs me because the message is there are many things to do and people should be creating a timeline that gives them more chances, not, dragging out mediocrity.
Yeah. So what's the best way someone can do that, do you think?
The right second opinion, uh, really good frank talk with the current doctor, You know, people have to explain what their goals are and really discuss, are things going well? How long do you expect them to go well? What can I do now to find the right moment? I like to tell people if something is going right, build on it. Most people wait, drag out what they're doing. When it goes back, then they scramble.
Mm-hmm.
And
Mm-hmm.
I like to have four things in place. And we're learning that the sooner the immunotherapy goes into the mix, the better the chance something really good will happen.
And now let's say someone joins a study. First of all, the study that we're following, without mentioning specifics, is there's still one patient in it, or has there been a second?
I think there are two now,
Two.
and
Okay.
there's a third that's probably due to come on, already scheduled
Hmm.
for about a week from now.
Mm-hmm.
So she's almost on,
Mm-hmm.
basically in, and I have three others that we're trying to clean up the lab tests and the eligibility.
Okay.
They will look like they're very close, and they're in very good shape,
Uh-huh.
unlike a lot of
And
patients.
how does it, do they approach you about doing the study, or is it something that you offer them as an alternative that they're unaware of? How does that
It's a
process work?
it's a mix. Some people ask, and other people I tell them, you've got a problem. This is a point where you have a chance to benefit from the immunotherapy, and you would have great backup on, that you could build on an immunotherapy success,
Hmm.
and not a, not look at immunotherapy as an all or none last resort or only resort.
And now, let's say these patients do well in the study. The study's relatively short, so when it ends, and you being their physician, you see that they're doing well,
We're,
how
we're
does
going
that
to
work?
be able to continue them on the drugs.
Okay.
It, it's not just data. If we're helping someone as we expect, we'll be able to continue giving them what's working,
Okay, very good. Now, the
and
same
we'll probably be able to build on it once we're after the magic window.
gain
So
momentum.
we'll be able to add a drug, take advantage of personalized medicine information, things that'll multiply the benefit of the immunotherapy.
Hmm. Now, the same can't be said for all clinical trials. Some are just experimental and they will not allow use after the study. Have you ran into those issues in other studies?
I won't start a study if that's a condition,
Okay.
and usually uh, that hasn't been a serious problem.
Okay. Very
In
good.
fact, most drug companies are more than thrilled to see a good result show up in an even better light. And there is a compassionate uh, release mechanism for drugs. So I'm not averse to doing the paperwork to allow someone to continue to get a research drug as a compassionate
Compassionate
release item.
use. Yeah, I didn't
Because
realize that
there
that
are
involved.
ways.
Yeah, I didn't realize that involved paperwork that the physician had to fill out.
It depends. It can be a lot of paperwork.
Wow.
But but it's not that bad because a lot of these more promising drugs have already gotten a compassionate release
Hmm.
for someone. And if your patient isn't the first, you can use the previous paperwork uh, to shorten the process.
I got you. So basically, right now, it's all about, at least in the research, seems to be immunotherapy as the most frequent type of study out there for
Well,
oncology.
that's what we're doing with Dr. Hoffman and Excella, but we're doing uh, vaccines, we're doing direct and regional types of immunotherapy with growth factors and cytokines, where we're making tumors in the skin disappear by injecting them directly, and you know, and the chemo is far from gone. I saw two people this week who were new complete remissions just with chemo and all drug and personalized. When we went in the lab and we found an anti-drug and we gave them standard treatment, they had partial responses, and then we added the drug that we found in the lab and complete remission.
Hmm.
Obviously, doesn't happen all the time, but this has been a nice week in
Yeah.
terms of seeing him. Had a woman in on Monday. She came in severely jaundiced, had three other drugs, wild up cancer, and she could barely walk. But an older lady, but a really nice lady, great spirit, good family, and to, frankly, to my total surprise, uh, 6 weeks later, the CAT scan's normal,
Wow.
and the lab tests are all normal. And I didn't expect that. Yeah, you never know.
You never know. And since the last interview, and we're going to do these follow ups every 2 weeks or so, whenever we
And
get a
now we're going
chance.
to give her immunotherapy to try to keep that remission going.
I see. Yeah, I'm starting to learn more as I interview you. So, anything closing remarks you want to add from the last interview we did till this one? Any interesting things going on? Obviously, you shared a couple of examples from the study in particular. Any follow-up visits with the patient? Uh,
Well, I did a consulting conference involving hepatocellular carcinoma. Uh, had a couple of people in from around the Northeast uh, with big liver cancer practices. And again, even I was surprised at how many new things have become available for this supposedly untreatable tumor. Uh, and we're seeing people who my colleagues are saying we they would never have treated them. People at the conference saying they never have treated them, but the person who did treat them, wonderful, it
hmm.
worked, and you know, a lesson. Happily, the guy was a former fellow of mine, so I hope some of that can do philosophy rubbed off on him. At least that's what it looked like, and very difficult. I probably wouldn't have treated that patient. But the next time I see someone like that, I'll know
It'll
to
be in
do.
your memory bank. Uh,
Correct.
well, we will follow up soon. Thank you for what you do. Keep doing it. We really appreciate these interviews. I know it's late over there. You're dedicated, you're changing lives, and you're learning more every day. So thank you very much, Dr. Brockner.
Sunshine for our second day in a row.
That's right. Good for you guys out there enjoying the good weather, and spring is here everywhere now. So thank you, Dr. Bruckner.
Till next time.
BrucknerOncology.com, and until next time, we'll catch you all later.